Good afternoon, everyone. My name is Haojia Li, and I am a master biostatistician and PhD student from the University of Utah. And today I will be presenting our work about joint modeling of long COVID symptom surveys in RECOVER. More specifically, we are trying to handle the missing data imputation problem in the symptoms. And I have no conflicts of interest to disclose. So our motivation is that, as we've been discussing, long COVID is characterized by clusters of persistent, fluctuating symptoms, and patients experience very different trajectories over time. So because of this heterogeneity, understanding the symptom dynamic requires longitudinal data with very good quality. And in the RECOVER study, we collected symptom surveys repeatedly, but the data challenge is that the repeated surveys are sometimes incomplete. And missingness may be informative because it might be related to some factors such as social determinants of health, comorbidities, and the participants' reinfection history. And if we simply conduct the analysis without addressing the missing data problem, our estimates will be very likely to be biased. So we need a principled modeling and imputation approach to handle the correlation across the symptoms as well as the longitudinal data structure. And here is an image illustrating the study design of the RECOVER adult cohort. And Dr. Fox has just introduced this as well. So we have the index date at the beginning of the timeline, and the enrollment is indicated by the squares, and the follow-up defined by every 3 months since the index date is indicated in the circles. And the symptom survey is collected both at the enrollment and the follow-up visits. So here I'm showing a mock-up table illustrating the data we are working on for a single individual, and the data has several rows with the number of rows denoted by NI, and each row represents a single symptom survey of the participants. We collected the baseline characteristics as well as time-varying variables, and the outcome is an NI by K matrix with, which includes binary indicators of presence of the symptoms. And the social determinants of health variables we included, which is collected at the participants' enrollment, included race, referral type, marital status, employment, insurance, healthcare history, food insecurity, primary language, and education. And the baseline comorbidities variable included immunocompromised condition, rheumatologic, autoimmune, or connective tissue disease, cancer, chronic liver disease, etc. And we also included the baseline age, sex, alcohol use disorder, and vaccination status in our model. The time-varying variables we included in the model included time since baseline or enrollment, and a binary indicator of whether the participant ever had an infection at or before the current survey. And if yes, we will include the total number of infections and the time since the most recent infection of the participant. We also included a binary indicator of whether the visit happened before the Omicron era. So we also just focus on the post-acute sequelae, which means that for the surveys happened before, within 30 days before the infection or 7 days after the infection will be excluded from our model fitting. And we assume in our modeling that symptom correlations remain constant over time. One thing to note is that the missingness is defined as the survey level, which means that if the survey is indicated as not recorded, the whole row for the outcome would be NAs. But if the survey is indicated as recorded, we will assume all the presence indicators as 0 unless it's indicated as presented. And the overall symptom survey missingness rate is 28.3%, but this plot is showing that the missing rate of symptom survey increases over time. The axis in this The x-axis in this plot shows the months since index. So here we collected the follow-up visits up to 54 months since index, which is 18 visits. And we calculated the symptom positive percent based on the observed data. And here we ordered the symptoms from the highest positive percent to the lowest. And unspecified pain, fatigue, GI symptoms, post-exertional malaise are the symptoms with positive percent over 20%. We conducted joint modeling for 40 binary symptoms for each patient, and our model included symptom-specific effects for baseline factors, which includes 3 groups of factors, social determinants of health, comorbidities, and others. And for the time variables, we used natural cubic splines to capture nonlinear time trends for time since baseline, and if the participant had any infection, we will also include the cubic spline for time since most recent infection, and we will also include the number of infections in our model. We also added a local latent variable to account for the within-person correlation. And we used maximum likelihood with Laplace approximation to estimate the marginal likelihood, which is implemented using the TMBR package. And after the modeling, we generated 10 imputation to fill in the missing symptom reports. So we are still working on refining our results. So I'm just showing some example of the results of the modeling. Our model suggested that the older age is associated with higher likelihood of brain fog, and vaccination has a protective effect on brain fog. And for fatigue, the model delivered a similar story. And here is a plot summarizing the performance. We tried to assess the performance by comparing the observed symptom positive percent, which was also shown as the bar plot I just presented, versus the complete symptom positive percent, which is calculated based on the combination of the observed data and the imputed data. And in this plot, we're using the solid dots to show the observed symptom positive percent and using the circles for the complete symptom positive percent. And we can see that in most of the symptoms, the observed symptom positive percent is higher than the complete positive percent. This potentially suggests that for the participants who completed the symptom survey, they are more likely to report their symptoms. And as a summary, we fitted joint modeling to address missing symptom data. And this problem is critical for research using long COVID research index. And our model leveraged rich covariate sets and handled correlation across the symptoms. And our model also provided clinical insights into symptom dynamics. And for the next steps, we're going to refine the models, and ultimately we're planning to integrate the imputation into downstream analysis, where the long COVID is the exposure. And last but not the least, I would like to thank my colleagues from the UNHA node of the Network of Biostatistics for Recover. Thank you.